I'd like to introduce today's Journal Club speaker, Dr. Schaye. She is an assistant professor of medicine at the NYU School of Medicine and has served as Hospitalist Director at the NYC Health Hospitals, Bellevue since 2017. She's involved in medical education across the continuum. Dr. Schaye is the Associate Director of Curricular Innovation at the Institute for Innovations in Medical Education and is a firm chief in the Medicine Clerkship. She's also a Farber Faculty Scholar in the Education for Educators Faculty Development Program, which is offered through the Department of Medicine. Her research is focused on developing and evaluating best practices to teach and assess clinical reasoning, and she is currently a CITM Fellow in Diagnostic Excellence. Dr. Schaye, and thank you for presenting today, and we will now turn over the slides to you.
Thank you for that introduction and allowing me the opportunity to share my work. Just to confirm, are my slides sharing now?
Yes, we can see them.
Wonderful. Okay. Development to train our faculty to teach clinical reasoning. So I think probably a lot of people on this call might be familiar with the Improving Diagnosis in Healthcare report now from almost, I guess, going on 5 years ago, really shedding a light the impact that diagnostic errors have on our healthcare system, and several calls to action in this report. And one of them is that we really need to do better in our education on the diagnostic reasoning process and enhance health professions education in this domain. But how well are we doing that? And so this is from 2018, so a few years following that report. This is the state of clinical reasoning education at U.S. medical schools, focused on undergraduate medical education, and this was surveying clerkship directors. And a lot of medical schools at this point in time were still lacking explicit clinical reasoning curriculum. Really, curriculum focusing on the diagnostic process of how we make clinical decisions. And lots of barriers cited, but one of the major barriers cited in this report is lack of faculty expertise, and that our faculty don't have the skill set to explicitly teach clinical reasoning, to really, again, break down the process and take their learners through this process. And so that's what our focus in our program at NYU is really focused on clinician educators, so those faculty that are engaging with the learners in their clinical environment, not necessarily in their preclinical years, and how they can better teach clinical reasoning in the context of patient care. So I'm just going to give a brief overview of our, we call it Education for Educators faculty development program, which is at the NYU School of Medicine within the Department of Medicine. And then this paper is focusing specifically on our workshop on clinical reasoning. So this is a year-long program, again, targeted at clinician educators who spend at least 20% of their time with learners in the clinical environment. When I say learners, that might be medical students, residents, and or fellows. It starts and ends, and I'll explain what a GOSTE is in just a second, a group observed structured teaching exercise at baseline and at the end of the program. And then we have 3 workshops focused on different teaching skills. The content that just was decided upon was based on needs assessment, both from various different stakeholders, so clinical leadership, education leadership, and then the participants, the faculty themselves, completed surveys of what they wanted to learn about. And so clinical reasoning was the focus of one of these workshops, and I'll talk more about that and our outcomes. At the end of each workshop, participants complete retrospective pre-posts and commitment to change statements, and I'll get a little bit more into that when I talk about our outcomes. And then between each session, they do peer-to-peer observations. They actually go into their workplace environments where they're teaching learners and do bi-directional observations and give each other feedback on some of the skills they've learned in the workshop and other skills maybe not specifically addressed in the workshop. So that's just, again, just a brief overview of the larger program. And so to hone in a little bit on some of those elements, and then the clinical reasoning workshop itself. So what is a GOSTE? So I think most people or more people are familiar with OSCEs, observed structured clinical exercises, which are, in simulation centers with standardized patients, an actor that's trained to play a role of a patient. And then there's a clinical challenge that, whether it be, taking a history, doing a physical exam. What an OSTE is, observed structured teaching exercise, is essentially where there's a teaching challenge. And so instead of an actor playing a patient, you have standardized actors playing learners. And that might be, depending on the teaching challenge, again, medical students, interns, fellows, whoever your learners are, nursing students, physician and assistant students, again, that learner can be different depending whatever domain of health professions education you're in. And then there's a teaching challenge. And so teaching clinical reasoning, giving feedback, these are examples of some of the teaching challenges. What a GOSTE is, essentially, it's just going through that in a group. And I'll explain a little bit of, what that looks like. It's not sort of like a one-size-fits-all per se, but how we operationalize that in our program is, so again, the outcomes of this study is based on our first cohort of this program. We're now in year 3. And so this is from November 2017 to November 2018. And so the participants in November did the baseline GOSTE. And then in groups of 3 or 4, went through the stations. And there were 3 stations mirroring each of the workshops that we then subsequently taught throughout the year-long program. One of those was focused on clinical reasoning. And so at the outside of the room, those faculty participants, they get their teaching challenge. And so in the case, mirroring clinical reasoning, they had to focus on guiding a group of learners. And so it's a medical student, an intern, and a resident on ward rounds, focusing on their clinical reasoning, diagnostic reasoning process of a case. They spend about, 4 minutes outside the room first, strategizing as a group. What are some of their challenges with teaching clinical reasoning? What are some of the strategies that they want to try out? And then one of the participants will stay in the room and take the lead. And as you see in the photo on the slide here, you have the participant and some standardized learners in the room. And then the rest of the participants go to the outside of the room and actually observe from the outside. They spend about 10, 12 minutes in the case itself. And then everyone goes back into the room and debriefs together and talks about some takeaway points. Through this process, it really helps foster that peer collaborative learning, and we get to learn from each other. And then also from a practical standpoint, from an implementation standpoint, it's less resource intensive. And so the participants did that as a baseline in November 2017, and then again at the end of the year-long program in November of 2018. The clinical reason workshop itself was the first in the series of 3, which occurred in December of 2017, so just to get the time frame. The standardized learners were also trained on how to assess the faculty participants, and I'll go into a little bit more about that assessment rubric and the training for it when I get to the outcomes of the study, and I'll show that to you. So the workshop itself was a 3-hour-long workshop. Just from the practical standpoint, we had between 25 to 30 faculty at a time participate in this program. This cohort, there was 26. And clinician educators are very busy people and difficult to schedule. So we do it the same workshop 3 times, and so there's 8 to 10 people in each workshop, so in small groups. We start off with a case-based interactive didactic, going over a framework to teach clinical reasoning and highlighting some of the concepts. And I'm going to go through just a few of these today. Obviously, I don't have time to go through the whole curriculum content. But really talking about, what problem representation owner script is and how to use that in your teaching, focusing on techniques to broaden the differential, really about systematic approaches, and subsequently we've incorporated a lot more talking about diagnostic schemas in this, prioritizing the differential, which really having to do with problem representation, illness script matching, and then diagnostic timeouts. And I'm going to go into this a little bit more detail. And the content we developed was based on, literature review, evidence-based best practices that are out there, and certainly experiences of teaching similar content to our internal medicine residents and our medical students already in curriculum that we've already implemented. Participants will then get to practice these skills in role play exercises where, the faculty will take turns playing a teacher, a faculty, and then the other participants will play the roles of learners, facilitated by one of the program, the Education for Education's program faculty. and get to actually try out these techniques with a case and role play, and getting feedback both from their peers and from the faculty expert facilitator. And then at the end of the workshop, participants completed retrospective pre-post assessments, assessing both their confidence and their likelihood of using these newly learned skills in practice. And then they also completed commitment to change statements. And so creating specific actionable items that they would then want to go ahead and implement into practice that they've learned from this workshop. And then we followed up on that 2 months later at workshop number 2, whether they actually implemented these skills in practice. And if they hadn't, what were some of the barriers? So I'm going to touch just on a few of the concepts. Again, I don't have time to, of course, go through the whole content, but just so we can have a little bit of a shared mental model here. So one of the concepts we highlight and talk a lot about is about teaching your learners about the concept of problem representation. And really, again, that's just your one-liner, but just in a more refined way, and really a concise synthesis of the patient's presentation, including the key demographics and risk factors, and the temporal pattern of illness, and then the clinical syndrome. And a good problem representation really puts that information in abstract terms, medical terminology, unified medical concepts, and semantic qualifiers, or another word I always like to say for that is like buzzwords. So like monoarticular arthritis is going to trigger one set of diagnostic possibilities, where polyarticular is going to trigger another set. And so an example of that is the difference between a learner telling you about a 54-year-old male with 1 day of right knee pain, 2 prior similar episodes in the past 2 years, and the patient reports no fever or trauma in the last few days. I'm sure we've all heard our one-liners from our learners along those veins. The difference between that and in a problem representation, a 54-year-old male with acute onset, episodic, monoarticular, large joint pain in the absence of preceding trauma or associated fever. And so we really spent time with the participants, one, defining the term problem representation. Some have heard of it before, some haven't. Very few are actually like using it in their educational or their personal clinical practice. And talk about how to implement this, and actually first just teach your learners what this is. And our learners are also getting this in other domains and in other parts of their curriculum, our residents and medical students. And then how to actually use this with your learners. And, if you're working with a group of learners, you can have different learners, each model, give their own problem representation, model your own. And it gives a language then on feedback, be like why you put things a different way, or why you made the right knee pain, why did you turn that into monoarticular large joint pain? And this gives you as a teacher language around guiding your learners through that process. And then it also helps in terms of the discussion of what you think is most likely on the differential, having an explicit language with your learners about matching how the patient is presenting the problem representation with what your learners know about the disease, and to talk about diseases in the format of illness scripts, which are kind of the typical presentation of a disease in these 3 domains: predisposing conditions of that disease state, the pathophysiologic insult, and the clinical consequences. And so that case example that I just gave probably triggered some diagnostic possibilities for some folks, and one of those diagnostic possibilities might have been gout. And so the illness script for gout, middle-aged male, dietary risk factors, the pathophysiologic insult, uric acid crystal buildup within the joint causing irritation and inflammation, presenting with acute onset, episodic, monoarticular joint pain, could be large joint, first MTP joint, in the absence of trauma. And certainly as you build on this and your more advanced learners, you could start including also what the expected diagnostic test results would be, what the treatment would be, and to really emphasize with your learners to continue to build on their knowledge of diseases and what they thought about gout before, and now they're actually encountering a patient with gout, to build on their illness scripts, and to compare and contrast how gout compares differently or similarly to other diseases in the differential. And so how gout is the same or different than septic arthritis or osteoarthritis, or, for example. And also to emphasize, certainly each disease does not present one way, and to build on their various illness scripts for one disease. And this really helps your learners to then activate that knowledge the next time they see a patient with joint pain, to activate that knowledge. And again, really helps us as teachers to give us a language around teaching that. The last concept I'm going to highlight before I get to the outcomes is we talk about the diagnostic timeout, and really it's just having a structured reflection, but again, a lot of this is making the implicit explicit, and doing this in an explicit way of like, let's take a pause, let's take a diagnostic timeout, and ask ourselves these questions. And I always find the most powerful of these is the what finding doesn't fit with my diagnosis and what can't we explain, but doing this in an explicit way. And again, this might not be on every single case. Maybe it's the ones you're more struggling with at vulnerable time periods, handoffs, but doing this in an explicit way really helps then your learners then integrate this into practice. So what were our outcomes? And so again, in this cohort, in the first year of our program, we had 26 faculty participate. 9 of them were hospitalists and 17 from the different, 10 other different medicine subspecialties completed the clinical reasoning workshop. We had a little bit of range in years in practice. The majority were more early mid-career with a medium of 5 years into practice, but we had a range of 1 to 17 years. So, kind of nice to see people that are still far into practice, but really excited to learn new things. And then in terms of completing both the pre and the post GOSTE, which were different, elements of this program at separate times, 20 faculty total completed all 3 of those elements. So in terms of the outcomes, first on the GOSTE performance, again, the pre-GOSTE was in November. The workshop itself was in December, and then the post-GOSTE was the following November. And our standardized learners, as I mentioned before, alluded to before, were trained on an assessment rubric, and we spent a whole session just having them calibrate their scoring and their assessment of the faculty. They completed on a 3-point Likert scale, well done, not done, partially done. For the data analysis, we dichotomized that into well done versus then not done and partially done in the same in a binary category. And so here you see the present well done. The only domain where we saw significant difference in improvement was the use of problem representation and illness scripts, which really the concepts we focused in on the most in this first cohort and this first iteration of this workshop. There was no difference between pre and post in terms of just the faculty's approach to how they taught about broadening the differential. There was a trend towards improvement in their strategies for teaching about prioritizing the differential that did not meet statistical significance. And they actually saw a little bit of decrease in their use of diagnostic timeouts to foster that structured reflection. In terms of the retrospective pre-post, so again, this was on an 8-point Likert scale, the participants' level of confidence of likelihood of using these skills in practice that they completed again at the end of the workshop. And we saw significant differences across all domains here, both in the confidence in teaching problem representation and illness script and how likely they were after completing this workshop, and the confidence and likelihood of teaching diagnostic timeouts after completing this workshop. And you see the effect sizes on the top. This was analyzed with using non-parametric statistics. So you see the R effect size here were large in all domains here. And so we saw a significant improvement with large effect sizes in all domains. And then lastly, the commitment to change statement. So at the end of the workshop, and I'll give you 2 examples of those in a second, participants completed specific and actionable items that they wanted to of these skills that they wanted to implement into practice. And then at 2 months, at the second workshop of this year-long program, we followed up with them whether they'd actually implemented those commitment to change statements and what were some of the barriers. And the majority of participants at least partially implemented. Only 4% reported insufficient skills, so they felt they had at least gotten the skills to implement, and that was not really a major barrier. The barriers we saw are the major barriers we always see with busy clinician educators, and not enough time, logistical barriers, and certainly just simply forgetting with all the things that they have to kind of balance and juggle. And so here we have 2 examples of commitment to change statements. One with a fellow who struggles with organizing their thoughts. I will focus on using and teaching the concept of problem representation as a means to systematically think through a case and create a differential. Another participant said, in pivotal moments in case presentations, I will take a diagnostic timeout to discuss what fits and doesn't fit. And so again, really kind of highlighting some of these key concepts about what they want to then take and implement into practice. So in conclusion, and some thoughts on some of the limitations and next steps. So here you have Kirkpatrick's hierarchy evaluation for medical education interventions. You get higher up in the pyramid, you see more significant impact of outcomes. And there really is not much written in terms of faculty development programs on training clinician educators. So those, again, the frontline faculty who are working with learners in the clinical environment on teaching clinical reasoning. And here, we contributed with describing a program showing that there was both knowledge and skills acquirement with the GOSTE improvements in skills. And then self-report of transfer of learning to the workplace with the commitment to change statements and self-report of implementation. Certainly a limitation that we didn't actually directly observe implementation. As I mentioned earlier, we did have peer-to-peer observations that weren't necessarily set up from a data analysis standpoint to analyze whether, and for this specific question about transfer of learning, specifically about the clinical reasoning teaching skills. Some of the other things to highlight in terms of like next steps and limitations, we've certainly made, iteratively made changes to the content of the workshop and the structure of the workshop based on some of the outcomes, and that we only saw a significant improvement in one domain in the GOSTE, really talking a lot more, integrated more, talking about broadening the differential and diagnostic schemas, change the structure of the role play exercises, to really kind of focus on one skill at a time to make sure that things got really, hammered home for participants. And the last kind of limitation just to talk about is the issue of context specificity and, how we best teach clinical reasoning, and so embedded in knowledge and context, and, in terms of teaching just this as general skills or general kind of concepts. But at the end of the day, we as a faculty, not just as faculty, but we really need a way to explicitly break down our thought process to teach our learners. And then it also really helps with importance in terms of being able to give feedback to our learners. Having this shared mental model of the language about the process really helps us with giving feedback. So certainly a lot of people to acknowledge and thank who have been part of this work, and our E4E program led by Ann Dembitzer and as Sandy Zabar. Certainly a lot of other faculty and administration and advisory panels that are involved. And with that, I think we'll open it up for discussion and questions.
Great. Thank you so much, Dr. Schaye, for the wonderful presentation. We'll open the floor for any questions or comments. And I think John wrote in the chat box that he has a question. You can feel free to ask it through your microphone or type it in the chat box and we can ask Dr. Schaye.
I would rather ask it by phone. Are you able to hear me?
Yes, we can hear you.
Okay. I actually had two questions. The problem representation, I wondered if there's any, so the first question has to do with the problem representation, and I wondered if there's any evidence that framing the case either for yourself or as you're presenting it to somebody else, if there's any evidence that improves diagnosis or improves patient outcomes or improves anything. My reaction to that case that you presented with the monoarticular arthritis was that I would much prefer the original presentation that described which large joint it was and when, over what period of time the two previous episodes were, and so on. It seems to have much more value to have the increased detail of that rather than large joint. Well, sometimes it matters which large joint it is, and so on. And so I'm not sure whether the problem presentation or representation is something that is just verbal between the learner and the faculty, or if it's something that shows up in the chart. Certainly in the chart, I would rather see the detail. So that's one. The other one is for the timeout. And you mentioned broadening the differential diagnosis. And I wondered if you bring up the possibility, I have an interest in checklists to help broaden the differential diagnosis because of the unreliability of our memories and the reliability of checklists. And so instead of generating this from memory, you could refer to a published differential diagnosis as sort of a safety check. So those are my questions.
Absolutely. Thank you for your question. So to the first one, so of course went through some of the curriculum content itself very quickly. But yes, the problem representation would obviously be after you've heard all the data, whether the learner is verbally presented to you, whether you've read it, in the chart before, and certainly, getting that information after you've heard the larger presentation. And certainly, I think one of the things we certainly always talk a lot about, and that conversation always comes up in these discussions, of really the benefit of having different people give their problem representations to help with that premature closure a little bit and see things from different angles. To the question about evidence, that is something we need more research and studies for. There is, in terms of what we developed this on, was evidence-based best practices, and there is evidence that generally strategies related to knowledge organization, which the problem representation illness script at its core in terms have to do with how we organize our knowledge, and strategies related to structured reflection, which the diagnostic timeout being a form of structured reflection, have shown to have some improvement in diagnostic outcomes, not yet in real patient cases, but in more kind of simulated type scenarios. So it's certainly an area of study that needs further research to jump to that next point of then does that translate in actual clinical practice to real patients. To the second question, just about the or a little bit more about the diagnostic timeout itself. So absolutely, and I didn't go because we weren't focusing this as much on this in this first iteration, so I kind of highlighted more what we discussed based on the outcomes of this paper in the first cohort, first year of this program, and as I mentioned, we're several years in now. We talk a lot about diagnostic schemas, which I think are kind of checklists in a way. That's not something that you absolutely have to have memorized, and to certainly look up your diagnostic schema every time you have a case for chest pain or shortness of breath. And again, I'm a hospitalist and internist, so those are the clinical examples that I see all the time coming up with. But and that I view that as a checklist in a way of that's not information that you have to have the tip of your brain, and to use those as tools and to have that systematic approach and use diagnostic schemas in that way.
Okay, thank you.
This is David Newman-Toker. Can you hear me?
Yes, I can hear you.
Thanks so much for being a fellow and for bringing this to us today. We really appreciate the presentation. I have sort of a follow-on comment and a related question. So, as I'm sure you know, you cited the article by Bowen from the New England Journal in 2006, and I'm sure you also know there was an accompanying editorial by Jeff Norman on that piece, sort of taking the opposite view that, again, there's this sort of tension in the medical education community between the notion of how much of this should be about structured problem representation versus how much should just be experiential learning in the kind of correct way and in the correct combination of cases, mixed practice and varied and unknown and so on and so forth. And that ultimately, I think, relates to kind of the question of what you're trying to get your educators to do and accomplish. And in the following way, which is that you've got a fundamental problem that you can either sort of teach people how to think about a case, or you can kind of expose them to lots of information where they have to go get the information themselves and kind of figure it out and sort of sift their way through it. There's some reason to believe that both are helpful, but is that piece of the puzzle coming into your educational approach, or are you resting squarely on the sort of formulation side of the equation as you teach your teachers in your sort of train the trainer approach? My only worry...
No, absolutely. And as I kind of I think alluded to a little bit when I was talking about limitations, and it's certainly obvious, right? It is certainly a conflict, and I think the answer is probably we need to do both, and we need sort of more evidence to kind of support what we're doing. And because I almost see it as almost like there's like from the larger curriculum standpoint, from like the residency program, and then in terms of what the frontline clinician educators need to do is kind of how I break that down a little bit, because I think the frontline clinician educators don't necessarily as much have control over what patients the learners are seeing, right? Because once they've gotten to that point and they're working with them on the wards in the clinic, patients you have are the patients you have. You know, different obviously.
That would be true. That would be true if you were talking just about the practical experience in the hospital. But we've just shown, I don't know if you're familiar with the work that Suze Coatwall and the crew did and presented at the Diagnostic Care and Medicine meeting in November here, using simulation, screen-based simulation, to just do lots and lots of cases. And we trained internal medicine interns in 9 hours to be twice as accurate with diagnosing dizzy patients in a simulated environment as their graduating internal medicine residency counterparts that had 2 or 3 years of extra practical experience. Do you see a role for that in the medical educator space, the sort of simulation? We're focused principally on information search, which is actually obviously very different than what you're focused on in the sort of problem formulation, where you sort of giving people the digest of the information then and asking them to kind of frame it. But in some sense, we think a lot of the problem is that people are not separating the wheat from the chaff and not acquiring information correctly in the first place, never mind sort of streamlining that into a simple one-sentence summary.
Yeah, no, absolutely. And that, I think that's like, I view that, and I agree, I think that's a really essential part of the story, and more from the larger curriculum standpoint, and sort of what are, both in terms of like the clinical experience and how else we need to augment experience and training, and whether that be, again, simulation, cases online or within the simulation center, and more OSCEs or those sorts of simulated. And I absolutely 100% agree that there's a role for that. And one of the things we're, in terms of just in the NYU residency program right now, is just trying to kind of a better handle on, just through what patients people are actually seeing, and doing it through a more kind of efficient means through our electronic health system, and then also compare that potentially to kind of what didactic series or other kind of curriculum, and comparing that to some of the performance metrics of some of our learners, and if that has any impact and informs how we design our curriculum, again, whether it be more simulation type cases, clinical experiences, and of the sort.
Great, thank you.
We have a question from Patrick, who says, who asks, when performing your needs assessment, did you get a sense of how often clinician educators were using the problem representation and illness script terminology before the GOSTE?
Yeah, well, so the pre-GOSTE is really the base, that was like the formal, I guess, baseline assessments. More from certainly just doing other faculty development previously, also just kind of anecdotally of your faculty really struggling to have a framework for teaching clinical reasoning, and certainly from the baseline GOSTE results, only 10% were using it, and that was in a way its baseline needs assessment. And again, we developed the participants themselves chose that they wanted a workshop on explicitly teaching clinical reasoning, and then we developed what the specific content based on, some of that, all that information.
And just in reference to Alex's question, it was Suze Coatwall's presentation at the annual conference. That was the simulation of the dizzy patient. I have a question also, which is, it's interesting that you report on what they saw as being barriers to sort of continuing to practice or to teach the trainees clinical reasoning, and you report sort of similar comments from other literature. And sort of to that point, I wonder if there's any plans on at least making part of this curriculum online, so then these busy clinician educators can at least have some training that's asynchronous. I understand that for the skill development piece, you really do need to see them in person, but if there are any plans to expand that, and also to the point of, them forgetting data, is having some sort of online presence so they can go back and reference the data.
Yeah, no, absolutely. So I mean, internally, yes, I mean, we have this, certainly those who have gone through the program have a centralized resource from all the content from the program itself. So for those that have gone through it, externally, certainly something that's always been on the plans is sort of to put some of this on MedEd portal, but has not yet actually happened. But so in terms of just kind of more, I guess, externally, I'm certainly happy to, of course, share materials. That's one of the other reasons too, in terms of just the implementation into practice piece and just thinking about faculty development framework in terms of the larger challenges of, most faculty development is workshop based or lecture series or those sorts of things. We've really emphasized more and really kind of built up more the peer-to-peer component of the program, which is more robust now than it was even in the first year of the cohort, to really help with that transferring of skills to the workplace and to have those bidirectional feedbacks. We have them, they get to choose what they want to observe each other on. We're not prescriptive of like, okay, with this peer-to-peer session after this workshop, you're going to observe each other on your clinical reasoning teaching. We have them, to get their buy-in and make it highest yield for them. We have them, talk about beforehand what they want to be working on though.
Great, thank you. Do we have any other questions or comments? I have one other question if we don't have any others for the moment. You had mentioned that the simulated learners had about 2 or 3 hours of training, so then they learned how to use the rubric, but ultimately you ended up having to dichotomize the outcomes. Did you find that that there was bias with them using the rubric despite the training, or was it more of an issue of the instrument that you used?
Yeah, I mean, the short answer is probably a combination of both. In the, we spent, they had essentially 2 3-hour training sessions, one on just doing the training on doing the case itself, and the second one really more focused on assessment. And what it also is, wasn't all the same standardized learners who were the learners in the pre-GOSTE as the post-GOSTE, because they were a year apart, and of course just availability of who's available in their schedules from a year. So that certainly probably played a role as well. And we did the same training for the pre and the post, but it was different individuals, and so certainly potentially a component of the reliability of the assessment tool itself as a potential limitation there.
There any other comments, or you can also feel free to type questions into the chat box. Okay, so I think if we have no more questions, we'd like to thank you very much, Dr. Schaye, for the presentation and for everyone for joining us today. Our next journal club is going to be on April 14th, and as Vanessa mentioned, we welcome any recommendations for those upcoming sessions. Thanks everyone for joining us. Take care.
Thank you. Bye-bye.
Thank you.